Morning all, and I'll be speaking about the approach to workup of patients with retinal vascular occlusions. So, how important is it to investigate, and is it really worth investigating patients? Well, the idea behind investigating such patients is to identify modifiable risk factors and also recognizing sight-threatening visual complications like macular edema, vitreous hemorrhage or neovascular glaucoma. So by identifying risk factors, we not only prevent recurrences in the same or fellow eyes, but also prevent further damage to non-ocular end organs. A good ocular examination can give us clues to the underlying etiological factors which predispose these patients to develop retinal vascular occlusions, namely glaucoma or ocular hypertension, anterior segment inflammation that can be seen in ocular ischemia syndrome. The presence of scleritis or episcleritis can point towards underlying collagen vascular disorders. Congenital anomalies like optic nerve drusen or prepapillary arterial loops. Presence of generalized retinal vascular disease may indicate pre-existing hypertension. The nature and number or the size of emboli can give us a clue to the originating source. And the stigma of past viral infection of the eye is also important, given that there is an increasing role of steroids in the management of these patients, especially with the prolonged delivery of the steroids. So the steroids will cause a decrease in the local immunity and unmask latent viral infection. Most commonly encountered underlying systemic disorder is systemic hypertension, which could be either essential hypertension or caused because of secondary causes like chronic renal failure. Acromegaly and Cushing syndrome can cause both systemic hypertension and diabetes. Hyperlipidemia is another important cause, apart from diabetes mellitus. Other conditions causing thrombophilia include antiphospholipid autoantibodies and hyperhomocystinemia, which are risk factors for CRVO. Factor V laden, protein CES and antithrombin deficiency are other causes. History of occipills, as Dr. Mahesh pointed out, is important in young patients. Also, hormone replacement therapy. Optic disc vasculitis, again in same subset of patients, is important. There are several other conditions related to the vascular occlusions, namely Behçet disease, important to clinically diagnose such conditions because straight the patients can be put on immunosuppressive therapies. Myeloproliferative disorders need to be ruled out. Polyarteritis nodosa, sarcoidosis, Wegener's granulomatosis, Goodpasture syndrome are other conditions. A patient who is already on hormone replacement therapy and develops a vascular occlusion need not be stopped or discontinued with the hormone replacement. But patients who have a vascular occlusion and anticipate having hormone replacement therapy, but this decision should be made very judiciously. So going on to specific entities, let us see what we need to investigate for arterial occlusions. In a patient with acute CRO and has a high cardioembolic risk with pre-existing underlying systemic disorders, one must ask for a cardiac echogram. All young patients without an underlying disease should also have a cardiac echogram so as to unmask a congenital cardiac abnormality. All adults must undergo a carotid Doppler scan because they have a propensity to develop atherosclerotic plaques in the carotids. Young patients with no obvious cause, one must have a high suspicion for raised plasma homocysteine levels. And all older patients must be screened for GCA by doing a simple test like ESR. There are several associations with CRO, as the previous speakers have dwelt with. It's always worthwhile to thoroughly investigate a patient with acute CRO because 90% of such patients will throw up some pre-existing systemic disease, most commonly systemic hypertension or diabetes mellitus, and almost half of these patients will have a structural cardiac anomaly. Carotid atherosclerosis is seen in about 45%, and 20% of all GCA cases will eventually develop CRAO. So does the type of embolus matter? Yes, probably yes. The calcific embolus is mainly seen on the disc. It's of cardiac origin, unlike a cholesterol embolus, which most likely originates from the plaques in the carotids, and fibrinoplatelet embolus can originate from either of the two. A few of the investigations are listed here, depending upon the type of embolus we are seeing or dealing with, and appropriate referral can be made. So does the age matter? So young patients with CRAO must be investigated thoroughly and be suspected for systemic vasculitis, cardiac disorders, trauma, cycling hemoglobinopathies, coagulopathies, or migraine. Ocular examination can itself give clues to the underlying disorders. If we were to do a transthoracic echo in such patients, it would show us abnormalities in about 45%. And the younger patients are more likely to have an underlying cardiac pathology as compared to older patients. So does the type of artery involved matter? Yes. And there is a variation in the extent and pattern or the spectrum of the disease, and it could involve the central retinal artery, branch retinal artery occlusion, or several combinations thereof. And like AION and ciliary artery occlusion would suggest a posterior ciliary insufficiency. So an isolated ciliary artery occlusion is much like a branch retinal artery occlusion and constitute about 40% cases of all retinal artery occlusions, and the workup remains the same as the CRAO. And AION and ciliary artery occlusion indicates posterior ciliary artery deficiency. Most of these cases would have an underlying GCA, giant cell arteritis. However, some of the cases can also have a non-arthritic origin. So combined CRAO and CRVO already discussed. Several etiologies associated. 20% each of these cases might have hypertension or diabetes. There is an increased incidence of vasculitis. It can also be caused by retrovalvular injections, aminoglycoside toxicity, and one must evaluate such patients for a hypercoagulable condition. If there is a given symptom or a finding, one must investigate on those lines, but in the absence of such, the patient will need a detailed evaluation. 95% of all cases with cotton wool spots harbor an underlying systemic disorders. So one must not ignore the presence of cotton wool spots, and this might indicate several of these underlying disorders like diabetes mellitus, hypertension, AIDS, collagen vascular disorder, cardiovascular disorders, blood disorders, high altitude retinopathy. These things can be elicited by the proper history taking. Radiation retinopathy, pancreatitis, metastatic carcinoma, septicemia, or acute blood loss. Fat or talc emboli should also be considered. So amongst patients who have amaurosis fugax, one must ask the history of hypertension and would want to know whether taking an evening or a night dose of antihypertensive. In patients who have atherosclerotic plaques in the carotids, it is known that these plaques secrete serotonin even if they do not cause a hemodynamically significant occlusion of the carotids. So the serotonin produced can cause transient vasospasm, and that can give rise to amaurosis fugax. Optic ischemia syndrome can also give rise to amaurosis fugax. So moving on to venous occlusions. Amongst patients with CRVO, one must rule out local factors like glaucoma and must work up the patient under these parameters. And most of these entities have been dwelt with. Now just one word that we must differentiate CRVO from simulating retinopathies like ocular ischemia syndrome and non-proliferative diabetic retinopathy. So does age matter in patients with CRVO? Here the dividing line is about 60 instead of 45 or 50 as seen in arterial occlusions. Patients less than 50 years of age tend to have better prognosis. Patients over 60 years of age tend to have diabetes, hypertension or carotid insufficiency, and ischemic CRVO is more likely associated with systemic hypertension as opposed to non-ischemic CRVO, which has a more propensity to be associated with diabetes mellitus. So in a case of CRVO, the line of investigations would be staged, and one would investigate, go step by step, and ask for a blood pressure, blood sugar, complete blood count, basic coagulation test, VDRL, TPHA, lipid profile, and plasma homocysteine as a first line. If this throws up something positive, you manage the patient accordingly. If not, then you move on to inflammatory conditions like ESR. If ANA is positive, then you go on to ANCA and also APLA. And if still you do not find a cause, then you are justified in asking for a third line of investigations to rule out hypercoagulable states. So in patients with bilateral CRVO or CRVO combined with CRVO, a detailed evaluation of hypercoagulable condition. Important to note, with ocular examination, if there is a symptom or a history, you work up the patient on those lines. If not, then a detailed evaluation is required. So in cases of BRVO, look for local factors. There is a propensity of 10% affection of the fellow eye, and FFA helps in delineating the extent of edema and ischemia and helps differentiate it from adult onset courts, and also avoids laser to collaterals. Younger patients tend to have hypertension, hyperlipidemia, and increased blood viscosity by the following conditions, namely malignancy, paraproteinemia, nephrotic syndrome, Behçet disease, or Eales disease. So to conclude, the line of investigation or the idea of investigation should be to identify the modifiable risk factors so as to prevent further damage to non-ocular end organs, and also to appropriately manage causes of visual impairment in that eye, also to prevent such occurrence in the same or fellow eyes. It's important to recognize sight-threatening complications, and each of these investigations have a bearing on customizing treatment for individual patients. Thank you so much.